So I think we'll just make a start because it is past and I know you'll be really busy. So hi everybody, welcome to our next webinar for today, which is Giles, who will introduce himself in a moment. If you just all put yourself on mute, but do feel free to ask any questions. It's really good, obviously, we like it to be as interactive as possible. If you have any comments or anything, it's the only way we can learn from these presentations and how we can obviously improve everything and our icon. So please do chat as much as you can. At the end, the presentation will be shared on the website with all the other ones. So if any of your colleagues haven't seen it, they can view it afterwards. Also, there's a little evaluation, which is the same link, but it's for a different one for each webinar. So please do click on there and fill it in if you can. That'll really help us. So I'm going to hand over now to Giles, who will do an introduction of himself and an amazing presentation. Thank you, Giles.
Thanks, Sue. Always dangerous to say someone's going to be amazing just before they start. But yeah,
anybody that's here is amazing.
My name's Giles Haythornthwaite. I'm a paediatrician, but I studied paediatrics to do paediatric emergency care and then got interested in major trauma, but then also the unavoidable problem of safeguarding. And I'm going to tell a story about major trauma networks and then why they've ended up being a really big stakeholder and supporter for ICON, and how that sort of happened, and what a great collaboration it's been for both parties, really, with this what is quite a difficult problem for everybody involved. I work in Bristol Children's Hospital, but I'm also part of the Southwest Major Trauma Network and part of the National Trauma Network. And during this story, I ended up being called the Paediatric Medical Advisor to ICON, but I have to say that none of the content of ICON has changed particularly much since it was already sorted when I arrived. So I'm not going to take too much credit for Sue and others' fantastic work. Let me just go through things. So first thing to say is the sort of national context of trauma networks. I'm not sure if the many people know this, but a while back in 2007, there was a NCPOD report into trauma care in the UK, and it showed it was really useless and not getting the same survival rates as America, and that's quite galvanizing for a bunch of British people to be told that they're not doing things as well as the Americans, particularly in healthcare. We're quite proud that you normally get good outcomes on those things. So at that point, that galvanized us, that there was 20% higher in hospital mortality rate from trauma in England compared to the UK. And then from my perspective, observing as a paediatrician, the fact that trauma is a big killer in paediatrics, and there weren't very many paediatricians being involved in that area, it was exciting to be part of that context and try and do something about something that looked like we could do better. And I'll come on to, it's still work in progress. Effectively, the major trauma networks did work, and they've published in the Lancet, they've dropped the mortality by 19%. So almost exactly that level of survival rate, which was quoted as being better in the US to the UK one. So that gap has really been closed. However, where it commented that the gap wasn't closed was actually in pediatrics and in the elderly people, and the reasons for that were that they're often presenting with things where the trauma network isn't necessarily geared up for, which is interesting. We'll come on to more as a talk. Because we were set up on your left, you can see that we were kind of set up when we set up our trauma networks. We're thinking, lots of people in road traffic accidents, we have to be ready for that. And then, of course, about 2 weeks into the being set up as a trauma centre in Bristol, the nurse that's job was to coordinate all the trauma care came to me and said, 3 of my patients, babies with subdural brain injuries, rib fractures, who've been injured probably by their parents, and I don't know what to do with them. You know, I'm not, so I'm not sort of geared up for this whole massive safeguarding challenge, and this I wasn't expecting this. So we had to rapidly locally reconfigure our trauma services, much the same as most pediatric services, to make sure that the people looking after the trauma cases had the right safeguarding support, peer support, and that we were really linked with our safeguarding investigation teams, and to make sure the staff looking after it, and indeed the patients and their families, had all the support they needed, and that we had really close working relationships with that. So this is some x-rays from a patient that I saw in the emergency department who didn't come in a helicopter with a pre-alert like most traumas. He was actually alerted by a health visitor. So at age 3 weeks, he had a bruise on his chin, and there was a whole safeguarding investigation, and the decision was that he would have enhanced health visiting, which nowadays means that a health visitor can actually come to your house, and that they sort of prioritize him to get extra reviews. On one of those visits, the health visitor found him to have a swollen leg, and they found this this leg was swollen, which obviously was the fracture. And the health visitor then actually made a decision that saved that child's life. She called an ambulance, and then stayed with the patient until the ambulance arrived, and then handed over the ambulance to the ambulance.
I think Giles has disappeared, everybody. That was a technical issue. Do apologise. He froze, so I presume we'll just give him a moment, probably hoping to rejoin.
I'll just drop him a text, Sue, and see where he's.
Okay, yeah, thank you, Sue. Do apologise, we can't always help our technology.
Sent him one, so could be Storm Agnes.
It could be.
Whatever it's called. Might be a good opportunity to do a bit of a health warning, actually, for people on the call who are parents or who are members of the public, who Giles's talk is likely to show some pictures and some talk about distressing symptoms.
Yes, absolutely. It's just starting to feel a bit like that, but obviously it's like you say, Sue. Hopefully you watch with caution. Hopefully you've got people around you, and it, there are going to be some distressing pictures. Oh, I think he's nearly back. Hi.
Here he is.
He vanished into thin air.
That's terrible. I have no idea how long I was talking on my own.
Oh, bless you. Giles, you were still on the slide with the x-rays, and you just said the help is to save the child's life. She called the ambulance and waited for the ambulance to arrive and handed the child over, and that was where I think you lost it. But not you didn't lose it, but that's where you dropped
where we lost you.
Well, I don't know what's happened. Do the same thing. Text me again if we're losing. I'll share again. I'll go from that slide. Wait 1 second.
You'll do.
Apologies all. Okay. Can you see and hear me?
Yes, we can. Yeah.
Fantastic.
Yeah.
Okay. Yes. So it was a proud moment. We were able to show the health visitor. We in the discussion mortality and morbidity meeting, we were able to invite the health visitor and explain exactly what had happened and link everything together from the beginning of the presentation all the way through, and it really sort of gelled with me and the team that we really needed to be reaching right back to the beginning of the pathway in and around the safeguarding of children if we were serious about improving the mortality for children from major trauma. Nationally, at that point, the Trauma Audit Research Network published through Fionn Davis's work that 50% of the major traumas of under ones were inflicted in nature, which was a really sort of chilling statistic, which really hit home with a lot of us and realised that where we needed to be putting our efforts was, not just road safety and all of the other preventative strategies, but that we needed to be serious about engaging with helping with child protection as well. I did a bit of background looking around at stats, and I found a stat that just sits in the ONS homicide figures for England, and it's got just a statement which says that as in previous years, you're more likely to be murdered in your first year of your life than any other time. And this is a stat that just sits. It's not, that wasn't a headline or anything. It just sits on page, like, I think it's 17 of a long report, which is governmentally published every year, and seemingly didn't seem to have that much action against it. And it's a stat that when I show quite experienced doctors, it gets a sharp intake of breath, because I think it's something that isn't talked about particularly. And I imagine from my own experience and also from certain reviews that the majority of this homicide figure is those shaken babies, and that momentary loss of control that we're all trying in ICON, and the ICON movement is trying to help with. And the figure has been up and down over the years, but it is always consistently above the all-age homicide figure. So those poor little infants that we're trying to help have got a serious risk, which is higher than being stabbed as a lone female in London, or even a gang member. Your homicide figure as an infant at home with your parents is higher, which just means that the resources and efforts need to be put there. And I think this argument has been effectively made. And I think it was linking this stats with, when we found Sue, linking these stats together that really made the argument to get funding and to open doors, and why there are so many regions have now effectively joined the ICON movement. It also in Bristol, by fortune, the national audit of child deaths is housed, and they every now and again do a deep dive into a particular type of traumatic or any death, and this graphic shows the big blue square is the total deaths in a 3-year period, representing 9,900 child deaths in a 3-year period. And then the smaller orange box is trauma. And then the smaller boxes show trauma from particular different causes. So they went down into, and you can see violence and maltreatment in its totality, which includes the knife crime and the shaken babies, is quite a significant group. To reassure you, we're not quite as bad as America, where you're more likely to die from gunshots in America than you are from any other cause in childhood. So we haven't quite got to that level yet, but we do need to address violent behaviour between children of all ages. The breakdown of that shows that you've got increases in violence inside urban areas. You've got boys more likely to die than girls, because presumably the gang-related effects are contributing to that, and effectively a lot of the data shows is almost entirely the perpetrators of the murder of infants is their parents, not stranger danger, and so that we need to address that. There's also clues. So 76% of the teenagers have had social care involvement at some point, and 40% of the infants. So there is opportunities for people to intervene. 40%, it's not a huge opportunity. So you probably need to capture, if you're trying to capture all of them, you're going to have across all people initiative, such as ICON, which has always argued that all people should get the ICON information, irrespective of whether they're urban or in a poor area, that there's no judgment made. And we believe that these deaths are happening in all economic groups, but there is obviously, if there are other stresses, you're at more risk. And these infants, they present when they've got subdurals. You can see here's a CT scan cut through. You can see this is the blood seeping out in the dural space, so subdural, causing pressure and pushing on the brain. This is a baby who's got so much pressure in their brain, their eyes are being forced out, so they've got sun setting. This is the skull fracture that we saw earlier. And we felt that we needed to make sure that infants were recognised when they came to emergency departments, and we were concerned that whether or not we could get their medical treatment improved, and that their recognition, speed to scan, and getting intubated, and all the things which have improved the outcomes for major trauma of other patients. So that's really gone in parallel with the major trauma, also wanting to make sure that we've got some preventative strategies. And you will have seen stats like this before in and around the abusive head trauma. 25% at 2 years have died, so they're not all just dying immediately. Some of them will be dying in a delayed way, and then 40% have got significant disabilities and support needs, which and there's real human tragedies to not only the child but also other members of the family that are affected, with custodial sentences and with life-changing events to their child, because I think it's life. And I think some of the parents that speak on this week will paint the picture of that, which much better than me. But just to see the suffering is quite galvanizing for action. So we did a whole myriad of things inside the trauma network and continue to look at every single part of the pathway. We've changed our resuscitation courses nationally, so that we've got more situations where we put our doctors in training to have to recognize babies that might have had abusive head trauma and how to manage that in a compassionate and timely manner. But we also have engaged with prevention strategies. So when we looked, spoken with the ambulances and made sure that they've improved recognition and alerting. We've got paediatricians into the trauma teams. We've spoken to people around stealth trauma. If babies got bruises, that they think about getting them scanned to make sure they haven't got abusive head trauma early, and make sure they've got safeguarding investigations going on. As we say, we're just talking mainly about babies today, but safeguarding in trauma is all ages. So in that middle school area, there's often areas of neglect, and then we've got this huge problem with knife crime, which is rising in the UK, despite everyone's best efforts, and needs continual investment. And there are quite a lot of linked up allies that we can find a way along with ICON, and a lot of the people involved with knife crime and violence reduction are big fans of ICON, and we'll be very happy to mention those strategies, as I will in anything I say about ICON. I'll always mention the knife crime needs the equal amount of recognition and investment. So growing up in paediatrics, the Back to Sleep campaign was very successful and totally changed the outcome from sudden infant cot deaths and SIDS now, and it was wondered whether there was something in and around that with in and around abusive head trauma. So we started looking around, found published data in New York, found some stuff from Canada, from British Columbia, the purple crying thing, and a lot of publications. And then, of course, we found and we saw all of their papers, which are pretty good. And we found the NSPCC hard-hitting video that got discontinued because I think they got distracted with the whole cyber campaign thing, you know, safety, and they've got a lot of things. I think it is still available and some places still use it, but not necessarily easy to deploy on big scale. And then I found ICON and then approached Sue Smith and the team, finding that they'd sort of done exactly the same sort of journey, but from a totally different angle, and had invented this fantastic system of communication, which has now been picked up by so many people, and it's quite inspiring to be. So rather than invent the wheel, I sort of jumped on the bandwagon and gave it a little shove as I got on, and tried to link it into the trauma networks and as one of their prevention strategies. The good thing about trauma was that because they were politically seen to be a success, they were quite high up in commissioning and were able to link us into quite a lot of government people, and that's how got hold of Jane Scattergood, as got her involved as the chief midwife, and just tried to start linking people together. And networking is a hugely useful thing, and now of course we've got a whole ICON network in its own entirety, which is just a fantastic thing. I know that when we look at the first slide where we've got the infants with abusive head trauma, the most frequent age is at the most frequent early crying stage. At the peak of early crying is the peak of abusive head trauma. We can see that in our trauma data, so it just links. Absolutely, we can see it as the crying rises, the chance of that abusive head trauma goes up and then comes down with the crying. It just is obviously shown inside the data. The touch points, I think, are really useful. I think the opportunistic touch point is the one that we're increasingly using, looking to develop more into the emergency department. So as a emergency paediatrician, we're helping to get a 7-minute brief out to the emergency departments in the country to see if we can get them also using ICON in and around their intermittent when they're seeing babies that are crying, which is actually quite a common presentation to emergency departments. Babies often come at this point where they start crying more, and the parents come thinking they've got a medical cause, and of course they will need sometimes an assessment to check that they haven't got a medical cause. But then the next thing is to give them coping strategies such as ICON at that point. And there's some evidence that ICON actually reduces or some evidence that coping with crying methodology in North America has reduced ED attendances. So it's also another impetus for clinicians to do that, because you know, we're struggling a bit at the front door of our hospitals at the moment. So there were piloted areas, well done piloting areas, and then really just the thing that I've observed, which I'm sure a lot of you have observed, is that areas that have taken ICON on have really owned it and like made it their own and have done their own local campaigns, which and I think is a real breeding the success. What we haven't done yet, and we're in the process of, is evaluating ICON in a national scale. Now, one of the things which will help us on that is that all the data that's been captured inside trauma networks. There's data on children's intensive care, which has got data in and around abusive head trauma, and the National Child Mortality Database, as well as hospital episode data. So there's quite a lot of data there that can be looked into to look at the rates more closely in and around abusive head trauma. and the other thing was that because it's rolled out regionally in different areas, there was also the opportunity to compare areas that went live with Icon against areas that hadn't gone live with Icon. So that opportunity is being grasped that we'll come on to. And then, of course, part of my story, and everybody in healthcare and everybody in the world actually now, is that the pandemic happened, and inside the pandemic, I got really worried, along with pretty much everybody, and went on local TV worried about it, about the lockdown causing social isolation and increasing unemployment, and all of the things that I thought might increase the potential for infants to be victims of abusive head trauma. Along with other injuries, and no longer getting you extended families, health visitors unable to visit you, social care at full stretch. And inside that, we were able to, I managed to create such a concern about that we sort of said, what can we do? And I said, well, can we get some Icon advice out to be delivered? And then that was when sort of Icon Light got launched, which was a system where we got midwives in the UK inside their briefing for the pandemic was to deliver Icon as part of their pandemic response. And a lot of them were quite innovative and owned it. Chose to give Icon advice pretty soon after birth, because that's the only time they could get to capture the dads, because the dads during the pandemic were only allowed to be at the birth and then pick the child up, but weren't allowed to come to the ward at any other time. Just horrendous suffering for those parents, and additional stress. But we delivered Icon, I think, then went up to about 56%. I'm thinking 50 to 60% of units picked up and did that one-touch Icon response. But I think that really put it out into the language of a lot of places. And luckily, Sue Anslow was in post and she was able to deal with the tsunami that came afterwards of all of the regions saying, yeah, we want the full package now. And this maps out of date much more of these. They aren't Tory. They're you'd like to think it was the Green Party taking over, but it's not. This is Icon taking over areas that aren't delivering Icon, and many more of these have now been shaded in green, and I think we are heading towards 100% coverage and have got funding to do that, which is fantastic. But on the pathway to do that, we've got this incredible controlled trial of being able to evaluate whether or not and see the impact of in the areas of going live on the level of severe injuries into infants, and we'll capture that and be able to report it in, as well as a qualitative analysis in a very structured, publishable way, and that's what will be happening in the evaluation. And there's a big grant into that, which is captured by Bristol. I'm not doing it because I'm just too biased of an Icon supporter. So I'm helping advise them and Icon, and I'm sort of stepped back from it. So one of my colleagues is who's doing that, who's got much more research time and a research interest, and that will look at the information exchanges and retention of between staff and parents, along with actually looking at the quantifiable abusive head trauma data to see if we can really bed it in, not only to bed in what's helpful in the UK, but we could potentially help other countries that could easily be struggling with the same problem. And that's me. I've whizzed through in less than 30 minutes with a gap. If you're still there, I'm very happy to take any questions. Shall I stop sharing?
Really amazing. Thank you, Giles. Very, very powerful, and obviously some quite upsetting pictures and information, but to me that is just a reminder of why Icon is so important to share with everybody. It's such a simple message because we can help to reduce this and prevent it. So, and as you say, we've got the 7-minute brief that we're going to send out, which we're going to launch out this week to via the NSG to be shared with all A&Es, because I think lots of people do present in A&E with young babies crying, and often maybe discharged home because they think it's colic and not actually given the information. So like you say, they may come in at 2 weeks and then come in again later. So I think it's really, really important that all the nurses and everybody.
One of the interesting things is now, I think, in those all children that die need to have a actual review by a multidisciplinary team to look at contributing factors. It's starting to come up in those discussions about whether or not the family have had ICON advice. So if you know, and it did stick with me that, you know, one of the ones that we came through recently, they were unfortunately from an area that hadn't gone live yet, but it's now like starting to become like a routine question in those kind of reviews. And I think, you know, it does sort of change the ethos. So I think also the attention to actually getting it all documented is really useful down the other end, that people know that it does change things. Yeah. Sue.
Thanks, Giles, as ever. Just really, really brilliant presentation. And there's so much data we can draw from, and you've really highlighted that for us. There's a couple of questions I've got. One is a cheeky one, really, and you might not know the answer, but do you have any idea about when the NIHR study is likely to be completed?
Jamie's asked the same question in the chat box.
I'm going to duck that. No, but I think they're doing well. I think it's more, you know, is like months, I think, rather than anything. They are under some time frames. I can come back to you on it, but I don't want to hold them to anything on. I know that they are on schedule.
Yeah, right.
There have been some particular hurdles, like the Trauma Audit Research Network's data in Manchester University got cyber hacked and has gone down, so that might be causing the whole of Manchester University. Sorry if there's anybody from Manchester University on the call, but I think a lot of their databases have been cyber hacked, including the trauma database, so that's compromised. I don't know if that's affected them, but I know that I've informally that some of their qualitative stuff's come back and is looking really good, and they're really happy with it. So I don't know the quantitative stuff yet. And I think they'll be quite careful keeping it under embargo. But you know, like I think we just have to wait. I'm sorry.
Yeah.
Exactly when.
Yeah.
We should get a an update. I'll get an update, and I'll let you know.
Brilliant. Thank you. The other thing I was just going to raise was about, do you know, where it is delivered? When we've done a survey, we've found that the data aren't particularly reliable, to be honest with you, but there's an indication that not everybody is delivering that hospital-based bit of the touch points, do you know, which is the most important one in terms of reaching dads. And I suppose that worries me really, because you know, if the incidence of abusive head trauma doesn't change, and an area isn't delivering the program as it's meant to be delivered, it doesn't mean it's not working necessarily. It just means it's not being delivered.
Yeah, exactly.
Correctly.
So
and just underline the importance of getting it to men, really.
Yeah, and I think the dad pad and that kind of thing is pretty useful, isn't it, from that perspective? But I think men generally aren't being are sort of forgotten, and there've been some really good publications about the Invisible Man, which is a publication from the Child Death Review Body, the Safeguarding Review Body, where they looked at this sort of forgotten man that wasn't engaged with any kind of support network in and around the baby being born, no social support, no anything. And then in fact, even after being the perpetrator, there was no after support for how that had happened and what, you know, they were completely forgotten and left out of society and those sort of things. So I think there's definitely there is more scope in and around it, in and around affecting quality. I do think strategically, once we've got it out there and we feel like we've got all of the regions have bought into it, we almost have to reorganize the whole thing to be a quality assurance system rather than a promoting the system, and then be sharing the quality improvements. And there needs to be some sort of way that we peer review and assess between regions. It might be that it's not just the local body that goes out, but actually say you take Hampshire and you go and see Dorset, and Hampshire and Dorset exchange ideas whilst they're reviewing each other's systems. And I think there is, you know, because I think one thing that really strikes me is that once a region's taken it on, they've really sort of owned it. But not only that, they've sort of improved it. Like there's so many amazing improvements and stuff that people have done, and it's how we managed to get those to be shared between regions and keep the standard of it up. I think you're right. How do you? We'll probably have to invent quality measures, perhaps.
Yeah, I think that's all for the very, very near future. And I suppose the research for me would be would kind of frame that. It would be the recommendations from that would frame the new structure of ICON. So yeah, very much.
Because what we don't want to do is create a system where, because the systems aren't designed properly for those staff, that a staff doesn't document or deliver ICON when the child's being born.
Exactly.
Just because they didn't know about it, because they weren't told, because the systems weren't set up. Something terrible happens to that child, and then in the review process, because it's become standard practice, that family say, well, we weren't told. You know, and do you know what I mean? There's a whole nother, create a whole nother headache potentially.
Exactly. Yeah.
But you know,
and I think in terms of the developments, local developments, just picking up on what you've said there, the talk at 3 o'clock will really show that. That's from Debbie Gibbons in Lancashire, and she has been amazing in terms of, you know, developing a Lancashire approach around ICON without diluting the message at all, without going off brand. She has been completely amazing in how she's driven innovative approaches to getting the ICON message to where it needs to get to. So that'll be really one worth looking at for folks. But thanks, Giles, absolutely brilliant.
No problem. Thanks, guys. Keep up the good work, everyone.
Just checking this note before we lose you again. Anybody got any other questions before Giles disappears? You don't get this man very often. And if you do, you don't get him.
Oh, I try to.
You're very precious. So now is a good time to ask him a question if anybody has one.
Thank you for your feedback in the chat. It's very kind.
There's lots of thank yous, very powerful presentation, lots of thumbs up in there, Giles. And I've obviously put the evaluation for the presentation in there as well, so please do that.
I'm sorry for the photos. I didn't give any kind of warning, but I think in a world where people watch Game of Thrones on TV without shuddering an eyelid, that the actual reality of life, I shouldn't have to make excuse for. But anyway, I should probably have warned. Okay, thank you very much.
Don't worry, because we did when you dropped off. We gave a warning, so don't worry.
We've seen this before, okay. All right, thanks everybody.
Brilliant. Thanks, everyone.
Brilliant, thank you, Giles. Thank you.
Bye.
So the next presentation, as Sue said, is at 3 o'clock, which just shows lots of innovative work from Lancashire with Debbie Gibbons, Safeguarding Midwife, Carla Clark, Safeguarding Midwife, and also Karen Tuzinski, who's Health Visitor Development Lead in Lancashire. So we'll hopefully see you all then.